Welcome, everyone. Thank you so much for joining us today. The time is now 12:01, so we will get started promptly for the sake of time. My name is Kayla Gillard. I am one of our admissions counselors here at the Celia Weatherhead School of Public Health and Tropical Medicine here at Tulane University. Thank you so much for joining us for today's Public Health Discovery Seminar, Between the Dashboard and the Bedside with Molly Mallory, one of our alum. Just some really quick housekeeping tips before we get started. We will have a Q&A session at the very end of today's seminar, so please feel free if at any point during the presentation, if you have any questions about a particular slide or something you would like elaborated on just a little bit more, feel free to drop that in either the chat or the Q&A, and we will answer all questions at the very end. All right, thank you so much for joining us, and I'm going to hand it over to Molly.
Thanks, Kayla. Hey, everyone. Thanks for joining. My name is Molly Mallory, and like Kayla said, I'm a Tulane Weatherhead School of Public Health alum, so really excited to be here today. Thank you for having me. So a little about me. Like I said, my path started right here at Tulane. I entered the health administration program in 2017 and graduated from the program in 2019. And while I was an MHA candidate, I completed my administrative residency at Access Health Louisiana, which is a network of federally qualified health centers. My main role as a resident was to support the Vice President of Population Health. So I spent a lot of time assisting with the implementation of our value-based contracts. So negotiating with payers, developing new clinical workflows, tracking and presenting our progress towards the implementation, things like that. And I really loved that work and wanted to see the fruits of our labor and experience it from the other side. So when I graduated with my MHA, I transitioned into a director of operations role where I managed two of the New Orleans outpatient clinics. And this was really where I got my first real look at frontline operations and what it takes to run a clinic and get patients in your door. After nearly 4 years at Access Health, I accepted a role at Children's Hospital New Orleans, now Manning Family Children's, as a senior strategic planning analyst supporting the COO. That was a completely different world for me, and from Access Health, that was mainly inpatient care, specialty care, and pediatric patients. So I partnered with our service line executives to focus on operational excellence initiatives. So we looked at things like OR utilization and ED throughput to see where we could remove bottlenecks or streamline workflows and ultimately get more out of the capacity and resources that we already had. But that was really where I gained a direct line of sight into how executive leaders think, what mattered to them, and how decisions got made at the top. And for the past nearly 2 years now, I've been at Ochsner Health as a director of strategic insights, where my team lives within the strategy division. So my role supports our regional and service line executives with strategy through data and market intelligence. A lot of my role is really about equipping our executives with the data and insights that they need to make their decisions, whether that's entering a new market or expanding a service line or understanding how we are positioned competitively. So a lot of my role really focuses on translating complex data into clear strategic narratives, combining things like our market intelligence, competitive landscapes, and our internal performance data to bridge the gap between what the numbers are telling us and what leadership should consider doing about it. So I've been really lucky to work with some incredible leaders and thinkers at all of these organizations and have been part of some really amazing teams. I've seen a lot of different ways of working. And after almost a decade in this field, I've started to notice some different patterns and trends. patterns that show up really regardless of the organization's size or geography or patient population. So I wanted to share some of those observations with you today to give you a look into these health systems and others and how they operate. So I have split my observations into two parts. The first really is general observations that I've noticed almost everywhere I've worked, but also I've heard a lot of these same things from peers that work in other systems too. So these are really general patterns that are local and national and that we're just kind of seeing repeatedly. So the first one, something that I think we all can agree on, is that healthcare does not suffer from a lack of data, right? We love data. We are very, very good at building frameworks and dashboards. I have not heard from anyone that health systems are suffering from a lack of information. We're usually drowning in it. So, I mean, looking at the screen, Epic alone generates hundreds of data points per patient encounter. We have quality dashboards, we have operational scorecards, we have financial reports, patient satisfaction surveys, the list goes on and on. But the data exists, right? We can track just about anything, and we do, and we should, right? That's not a bad thing. Structure matters, measurement matters. You can't improve what you can't see. But as valuable as that is, it's also what can get us in trouble sometimes. Analysis paralysis at systems and in healthcare is a very real barrier. When you spend more time reporting or building your data and less time improving it, that's also a barrier. And I think that one of the problems is that organizations don't really know what to do with all of this data. And a lot of times, too, they don't really agree on what matters most. So I've sat in rooms as, an operator where we're looking at throughput metrics. And then in the room next to us is the quality team, and they're looking at readmission rates. And down the hall, the finance team is looking at margins. And then across the hall from them is the executive team, and they're looking at a balanced scorecard that has all of these elements in it. And none of these groups are talking to each other, right? I've been on teams where we're tracking 40 plus KPIs and we're still not able to fully answer what our top three priorities are. It's not that we're not working hard. We are all working very hard. We all have a lot of data and we're all trying to use every ounce of it, but we don't have those shared priorities all the time. And so many organizations have the appearance of a data-driven organization, or they have the perception that they are part of a data-driven organization without the actual alignment that makes all of the data fully useful. And to me, that lack of alignment really separates the average health systems from the excellent ones. Another reality is that most health system strategies and mission statements sound different, but they really say the exact same thing, right? These three examples are all real examples from local health organizations. And truthfully, almost everyone's strategy and mission statement in the state, in the country, everywhere reads like this. You can swap the logo on most strategy decks and they still read as true. And there is something reassuring to that, right? Like it's very clear that we are all working toward the greater good. We spend so much time on how are we going to differentiate and serve more patients and beat our competitors and meet our goals. And that's important. That's our job. But it's also nice to know that at the end of the day, everyone wants to serve their patients and their communities in the best way possible. But good intentions and good strategies aren't always the same thing. So at some point, your mission or your strategy really has to translate into real choices. And that's where it gets hard. Because when your strategy sounds like everyone else's, it becomes really easy to avoid making choices altogether. You want to keep everything on the list. You want to serve everyone. You want to make everyone feel heard because that's what you're advocating that you're doing. But what you end up with is a plan that feels good to present. It looks good on your website, but it doesn't actually tell you what to do. This third observation was probably one of the most surprising to me, if not the most surprising. And it's the difference between the strategic planning phase and the execution of said strategic plan. So for those of you who have never been part of a strategic planning season, as I like to call it, it's very exciting. It's energetic, it's hopeful, leadership is very engaged, ideas are flowing, anything is possible. It's that kind of mentality. Teams are asked to take a step back, look at their business, and really think big. Templates will go out, slide decks will get built, workshops will get scheduled, all the things, right? And it feels like progress because there's a lot of activity and alignment happening. The output of all of this excitement and activity is usually a very polished plan and a very clear set of priorities for the next few years. Everyone passes out praise for how well thought out the plan is, or how well they presented the data, or how big of goals they set. And we celebrate the completion of the plan as if that's the milestone itself, like that's what actually matters. It's almost feels as if that the work will naturally follow or that it's already done simply because we wrote it down. So what shocks me most is what happens right here, right at that red flag. At that red flag really is where strategy lives or dies. A surprisingly large amount of organizations stop right at that red flag. They treat planning as the finish line instead of the starting point. And the shift from planning to execution happens, and you lose all the energy. It completely drops. The energy that you took to build the plan is not matched when it's time to implement it. And so, because of that, initiatives sit across multiple teams, and there's no single owner driving the outcomes. Progress isn't really tracked or revisited like you thought it would be. And the plan just becomes something that we reference at best and not something that we run. I've been on teams that spend months developing a 5-year plan. It's beautifully designed, it's fully approved by the board, everything about it is great. And then we file it away and we never operationalize it. And it's as if the planning was the whole point. And it is easy to understand why, right? If you just compare the two pieces of this. When you're planning, everything is theoretical. Planning is orderly, the markers are erasable, the budgets are balanced, all the numbers add up. There's no surprises, there's no natural disasters, there's no epidemics. And execution is really messy. It's real life, it's full of competing demands and unpredictable human behavior. But that's the real work, right? The strategic plan is just the roadmap, and a lot of health systems surprisingly forget that. So everything I just described, the prioritization problem, the generic strategies, the celebration of plans over outcomes, those are average habits. You see that a lot. Now I want to shift to what the best health systems do differently. And again, this is a collection of observations and tactics that aren't just from my personal experience, but from peers at other systems, locally and nationally. So this is happening across the board. This first habit to me is the most important. As I mentioned earlier, when I worked at Access Health, I was very involved in our value-based contracting. So for anyone not familiar, value-based care is a model where healthcare providers are reimbursed not for the volume of services that they provide, which is our traditional model, but for the quality and outcomes of the care that you provide. So instead of getting paid for every visit, regardless of outcome, you get paid if your patients are getting their preventative screenings, if your diabetics have controlled blood sugar, if you are keeping people out of the ED unnecessarily. It's a very fair, logical system. Diabetic patients need this, this, and this every 3 months. Hypertensive patients need this, this, and this every 6. all patients need this screening at this age. It's very, very clear parameters on paper. Take colorectal cancer screenings, for example. On a dashboard, super simple. It looks just as is. You're at 67% and the target is 80%. That's your gap. All you have to do is identify your patients aged 45 to 75 who are due or overdue for their screening and refer them to get that screening. I remember thinking as a resident, this is so easy. They give you the goal, they give you the answer key, you hit it, that's it. That's all that it takes. This is so how are we not at 100%? This is so easy. And then I went to work in the clinics and I laughed at how gullible I was because I went from building the dashboard to then being the person that those dashboards were measuring. I learned very, very quickly that that number, that 67%, is just a number, right? At the end of the day, data is just numbers. The data does not tell you that the patient who hasn't completed their screening works two jobs and they don't have reliable transportation. It doesn't tell you that your medical assistant flagged it 3 times, but the patient kept saying, oh, we'll worry about this at the next visit. It doesn't tell you that your clinic is understaffed that week and the follow-up call never got made. It doesn't tell you that the patient's insurance just changed and they're not sure what's covered and they can't afford to pay out of pocket right now. Every data point that we have is a person having a complicated life. And that's not a flaw in the metric. That's not a problem in how we build the data. That's just the nature of the data, right? The whole point of data is to compress reality into a measurable number. But the best health systems never forget what got compressed and removed when we were building that number. Another example is this 100,000 patient opportunity. So this is essentially saying, in a certain region or a sub-region or a state that when looking at certain markers, patient loyalty, geography, all of these different habits of your patients, within a certain region, you have about 100,000 patients that are up for the taking, that aren't super loyal to any other system. It helps you kind of set a marker of what is left in our communities that we serve. And many of our regions in the state are seeing a lot of slowed population growth. So a lot of our systems are trying to quantify this number and trying to figure out their true, real opportunity. What do we need to be building? How much is our area growing? And how do we serve everyone that needs us? They're trying to understand all of these things. Of the patients that we don't currently serve, who is still out there? Where do we have the opportunity to attract a population that needs the services that we provide? Which specific communities need us the most? And there's many, many, many different ways to reach this estimate. But the most important part of this calculation is understanding that these estimates are purely directional. So a lot of external factors can and will affect that number. If you think about New Orleans compared to Baton Rouge, I mean, that's two totally different populations. And the best health systems know this, right? It's not that that 100,000 number is incorrect or they don't trust the data. It's that they know when to layer a level of reality to support it. That 100K needs a reality check. Local dynamics, for example. Local dynamics of an area matters. The culture and the politics and the loyalty of a community will absolutely affect your opportunity. Again, just think about New Orleans versus Baton Rouge. They're only an hour and a half away. Completely different culture, completely different politics, completely different loyalty. And so that affects everything. Average systems make the mistake of treating these metrics on the left as the full picture. So when they miss a goal, they say, oh, we need a better dashboard, or we need to slice the data differently. We're missing something here in our data. And then they build another report and try again. High performing systems build the leaders and the understanding of who can hold the dashboard in one hand and the operational context in the other and synthesize the two. None of these things on the right are in your dashboard. You probably will not see them. And yet every single one of them will determine whether you hit that number on the left. So this second habit of high performing systems is if your strategy never changes, you're not using your data. Now, this one may make some people uncomfortable, and that's okay because we've all been taught that a strategy is associated with long-term stability, and this is our guiding light, and it's our North Star. And you can always refer back to the strategy to know where we stand as an organization. And I also know I just said, don't blindly follow your data. Those things are still true. The strategic direction of an organization should be stable, right? Your mission, your values, your major investments, those do not and should not change with every new report. But the playbook, the specific initiatives, the resource allocations, the operational tactics, those should absolutely respond to new information. And the best health systems are nimble in this way. I've worked with leaders who, in their strategy debrief meetings or planning for the next strategic cycle, explain why they didn't reach their previous goals by saying things on the left. We knew we wouldn't reach this goal because X happened. We had a plan and it was a good one, but unfortunately, it just didn't work out. And that's all you can do, right? It's a very backwards looking take, it's very reactive. They treated the data as a rear view mirror. But really, your data should be a navigation system. If you're on a long road trip and all of a sudden you reach a road that your GPS says you need to be on, but it's closed, you don't just turn around and go home. You don't park the car and wait until the road opens again. It's the exact same thing with data. If you're not willing to change your plan when everything else around you has changed, you're not really navigating anything. And if you're not changing your strategy based on what you're learning from your data, then your data is not doing its job. And to add another layer, I mean, we all know that health systems operate in an environment of constant disruption. We have staffing shortages, public health emergencies, leadership turnover, things like that. If your strategy only operates under ideal conditions with very clear, strict parameters, it just will not survive reality. And the best health systems that I've worked with or heard about or read about have these built-in pivot mechanisms. So they have regular strategic reviews. This isn't just an annual check-in meeting, but they meet regularly about this and they ask things like, is this still the right goal for us? Is this still the right approach for us to reach the goal? What has changed in our environment that we may need to respond to? And when the data warrants a change, they make it. So that when you're in your strategic planning debriefs or you're planning for the next few years, you look like the organization on the right, where you say, when X changed, we pivoted our goal to Y. That's very proactive. They know the exact moment where things changed for them and they knew they had to adjust. That's a system that's actually using their data. And that type of adaptability is, again, what separates the good from the great. The quicker you accept that reality and pivot, the better. So the final habit of high performing health systems is strategy doesn't fail from lack of quality. It fails from lack of clarity. So like I spoke about earlier, almost all of our strategic plans in the city, in the state, in the country are very similar. When a strategy doesn't work out, it is not because the plan wasn't a good one. We are all pretty much saying we're going to do the exact same thing, and yet some organizations get it done and some don't. Oftentimes, leaders like to gain momentum around strategic planning by saying things like strategy is a team sport, or we win together and we all play an equal role in all of this. And they're right. But every team sport has positions, right? There's no high performing team that walks onto their field, that walks onto the court without knowing their specific role. And that's the piece that we sometimes miss in healthcare. A strong strategy is not about everyone doing everything. It's not to make everyone feel included and invite them to all the meetings. It's about everyone doing their part really well. So as an analyst, your role is to validate that the data being delivered is clean and accurate, and then you need to generate some actionable insights from that data. Your data that you produce will be used to inform projections and goals for the next few years. So it's really important work. The work that you do shapes the targets that your entire organization will be held to. As an operator, your role is to turn that data into a workable metric. So you have to understand the nuances and logistics of the day to day and really figure out how to get that done and how to meet your goals. You are the bridge between what the data says and what actually happens on the floor. And then as a leader or an executive, you communicate and prioritize the strategy, you remove roadblocks, you hold your teams accountable. The vision that you communicate and the systems that you build are only meaningful if they produce lasting outcomes. So it's the leader's role to remind everyone that the plan itself is not the destination. In the average health system, these roles bleed into each other in ways that often creates confusion or can diffuse accountability. As an analyst, I have been pulled into operational decisions that I don't have context for. As an operator, I have been blamed or held responsible for strategies that I didn't make or I couldn't change. And then leaders sometimes get too close to execution and lose that altitude that they need to really see the whole picture. The best health systems are very clear about who does what. And clarity of roles, by the way, is not about creating silos. It's the opposite. It's knowing where your contribution starts and stops, and then trusting people in the other roles to do their jobs well, too. So what does this look like in practice? This is a very typical strategic initiative. Grow your new patient population by 3% over the next year. Good systems ask their analysts to pull last year's new patient count, add 3%, and make that our target. Pull a report, send it out monthly, and we'll see how you do. We have a year to get it done, lots of time. Great systems ask their analysts to first work to define new patient. So make sure that all of our systems are consistent and speaking the same language. A patient that's new to cardiology but isn't new to the system, is that still a new patient? How that distinction can really change your number entirely. So the first priority is to determine whether we're all even measuring the same thing. Then, instead of that new patient goal being for the entire region or the entire system or even just one clinic, you segment your population to make this number more achievable. So, where are our current patients from? Where are they coming from? Where do they live? How did they get here? Were they referred to us or did the patient find us online? You also should look at where patients are leaking, right? Where do we have referral drop-offs that we need to maybe suggest some better collaboration between two groups? Where are we seeing high no-shows? Analysts really dig in here. They know that growth isn't just acquisitions, but it's also conversions and retention too. So you're taking many different things into account for this one seemingly simple metric. And then finally, they don't just track volume, they track yield. So which referral sources, which access points, which service lines are converting at the highest rate? Of course, you're tracking this in real time if possible as well. But you're working to actively identify where your top priorities are and your top performers are and where your top opportunities are and sharing that throughout the team. Moving to operators. Operators at a good system will likely be told to open their schedules, right? That's always the first step. It's just one of those, if you build it, they will come type solutions, which you absolutely do need to build it. But Oftentimes, we think it's working because we're seeing more patients in a day. You say, oh, we've opened our schedules, we've added 5 more slots, and we've filled them all. But what you've done is allowed your existing patients to be seen earlier, which is a great thing. But is that what you set out to do? No, not here. You still need to acquire those new patients. So you open schedules, you wait for them to fill up, and then at the end of the month, you look back and you notice, oh, these were just our existing patients. We really haven't grown our population at all. So you think, what's next? How do we fix this? And you restart the process again at square one. Operators at great systems start farther back than the opening of the schedules, right? So they may audit the new patient scheduling experience from end to end. How many clicks, how many days to first available, how many steps before a new patient gives up. If I were a new patient looking for healthcare, would I even want to come here? And if not, you work to redesign that process. You may open same day or next day availability for new patients only. You may work to reduce the amount of clicks it takes to get an appointment scheduled. You work with other departments like your data and marketing teams to say, okay, where is the need? Which age groups, which genders, which subregions have the highest need for our services? And then you promote in those areas. Great operators also empower the front line to flag any friction. So the team members scheduling patients know exactly at what point we're losing them. They make these calls all day long. And of course, great operators are constantly reviewing their data to see if their efforts are paying off. And if they aren't, they pivot. Finally, leaders. Leaders at good systems know the goal and they endorse it. They communicate it to their teams and the board, and they keep everyone informed and they check in regularly. And when issues arise, they're the ones that escalate it. Leaders at great systems, again, go farther back. So they set the why before the what. They know that it's not just about increasing our patient population by 3% just for the heck of it. That's the what. But the why is that we are the only organization in this state that offers this program, and it's our duty to find the patients that need us. Or the why is we know that many of our patients are uninsured or underinsured, and our current clinic location is all the way across town. So it's our duty to meet our patients where they are. So we need to open a clinic closer to that population, and we need to put it next to a bus stop so that the patients in the surrounding areas can reach us more easily too. They connect the number to the mission before connecting it to revenue or performance. They also identify a few obstacles that only they, as an executive or a department leader, can clear. Something that you know your team has been waiting for approval on. So some sort of budget approval, or maybe a new piece of equipment, or maybe an FTE to help you get the job done. It's very important that these leaders find these things in month one to gain momentum and not in month 9 when things start to feel desperate. Great leaders start at the beginning. And they also ask about progress in every team meeting, right? It's not to pressure the team members that are working to get this done, but to signal that this is real. This is really what we need to be focusing on. What a leader asks about consistently becomes what the organization pays attention to. So you can see that none of these things are big industry secrets, right? It's very basic practices. And it seems like the gap between good and great really comes down to how you do the basics. Most systems and great systems are working with the exact same materials. They have very similar patient populations. They have very similar workforce challenges. They have very similar financial pressures. The difference is not what they are dealing with, but it's how they respond to it and how they use what they have. So Good systems use data to report their work. They pull up a dashboard, they see the number, and they move on. Great systems use data to interrogate. They see a number and they ask, why? How? What's driving this? What do we do about it? They also measure outcomes and not just effort. So, is what we're tracking even what we should be tracking? Did it change anything for our patients or our community? What are we doing all of this for? Good systems treat strategy as an event. They write it one time, you set it, and you forget it. Great systems, though, treat their strategy as a playbook. It's something that gets revisited and challenged and adjusted as your reality changes. And when it comes to roles, like I said, there's a well-intentioned idea that everyone should be equally involved in everything, but shared accountability often becomes no accountability pretty fast. Great systems are really clear about who does what. Analysts analyze, operators execute, and leaders lead. Everyone knows their role and they stay in it. And finally, culture. Good systems throw a party when the plan is done, but great systems know that the plan is just the beginning. The real work and the real celebration comes when the outcome is achieved. They know that activity does not equal impact. So I want to leave you with this. I know I talked a lot, but what I spoke about really boils down to these three things. The first is become fluent in your data, but know its limits. So the reality in healthcare is that data literacy is really no longer optional. Every health system in the country is either calling itself a data-driven organization or actively trying to become one. That train has fully left the station. So the sooner you get on it, the better you'll be, regardless of what role you end up in. So really take the time to learn your data, right? Understand what it's actually made of, where it comes from, what assumptions are baked into it. Because when you understand the construction of the data, you can then understand its credibility. And that will tell you where the data should end and the reality should begin. The second is to remember that patients are just people, right? These are real people in real communities making decisions about their health. It's very complicated work and it's very unpredictable. And also remember that you are a patient too, right? We work so hard at standardizing everything in healthcare and trying to predict everyone's everything. But think about how you interact with the healthcare system. I am sure, I know I don't, we do not all return to our PCP exactly 1 year from our last visit. I'm sure we do not all answer the phone every time our doctor's office calls to schedule our referral. I am sure we have gone to the ED when we should have gone to urgent care. Like we are unpredictable and we're part of this industry. We're not trying to be unpredictable, it just is what it is. So remember that. Don't try to build strategies or dashboards assuming everyone will behave perfectly. It's really important to stay nimble there. And then finally, don't overthink what it takes to be great. The highest performing organizations that I've worked in or studied or heard about are not doing anything revolutionary that no one else has thought of. They're doing the basics with more discipline and consistency than others. So at the end of the day, we're all just trying to make our communities better. And the difference between good and great really is a choice that we are making over and over again. But remember that the basics will take you a lot farther than you think. So that's all I have for you. Thank you so much for your time. I hope this gave you a different way to think about health systems and how they work. That is my email. Please reach out if there's anything that I can help you with. And I'm happy to take any questions you have.
Thank you so much for that wonderful presentation, Molly. I'm sure we all learned some nice tips and tricks. I really love your good versus great analogy and examples there. So now we will take time for that Q&A. So please feel free, drop any questions in the Q&A or in the chat. It looks like we have one already. So Let's get started. Our first question is, what are some ways your health system has addressed patient problems, like rides to appointments, access to internet, etc.?
It's a great question. And it's varied across the different organizations that I've worked at. One organization that I feel like does this incredibly well is Access Health Louisiana, simply because they have to, right? Access Health Louisiana serves the most vulnerable patients in the state. A lot of our patients did not have reliable transportation. They did not have internet access. They really didn't have any health literacy or education when it came to their chronic conditions or, what steps they needed to take in their health. And so I think still do a fabulous job at meeting patients where they are. To speak to some of the things that we did when I was there in our New Orleans clinics, we knew that most of our patient populations were diabetics and hypertensive patients. And so what we started to see was, it was a lot of our patients didn't weren't able to come in as often as they should as a diabetic patient to get their eye exam, to get their foot exam, to get all these things checked in the amount of time that they had. The bus was running later. They couldn't get a ride. They couldn't get off of work. So some of those things that we do is you lengthen their clinic visit, right? You kind of have them as a floating patient. You really become partners to your patients to understand I know this patient. I know he's working 2 jobs. He's probably going to be late. So let's extend his appointment time and let's get a diabetic educator here on this day to make sure that you can come in with the provider and explain everything, answer all of their questions so that they don't have to come back in 3 months. We're going to knock everything out today. Another thing that we did was we partnered with local colleges and schools of pharmacy to develop diabetic and hypertensive patient education classes. So we kind of scattered them throughout different days of the week and times. And we invited all of our diabetic patients to come, for an hour, and we would have our school of pharmacy come and present, and we'd have our providers available, and we would say, okay, what issues are you dealing with? What questions do you have about diabetes? And so you really learned very quickly that they knew they were diabetic and had no idea what that meant. And that's perfectly understandable. I worked at the clinic and couldn't say it back easily, right? So we had to really meet the patients where they were. This is what this means for you. This is what this lab means. And so we kind of held almost like an office hours for our chronic conditions to really meet the patients where they are and feel like we were partnering in their healthcare because we were. It was so much more difficult getting patients in our door, knowing that they aren't able to prioritize their health like they should. And so we piloted a lot of different tactics like that. We also applied and received a lot of grants for things like home health monitoring and getting patients internet access for their telehealth visits. So I found Access Health was really the greatest organization at doing that. It really was a true example of meeting patients where they are.
Thank you for that. Those are some really great examples. Um, for our folks, please feel free, drop those questions in the Q&A or in the chat. Our next question, how do you address strategy fatigue and how to keep the momentum going for planning projects?
Great question. I'll let you know when I figure it out fully. I think it comes down to prioritizing what you're measuring, right? It's really hard to do if you're not the leader or executive because they're, of course, that's the reality. They set the tone. But as an analyst, I think, that your data front to back. You are the expert in your data. So I think listening into conversations to really get to the root of, okay, we're saying we want to do all these things, but what do we keep going back to? Like, what is that metric that I'm keep getting a request to check on? Try to notice the pattern of this is what everyone keeps asking me about, or this is the most visited dashboard, and try to steer your strategy or your ideas or your initiatives to what everyone's already looking at. I think just speaking from an analyst perspective, a lot of times when you receive a request for, I want this metric, and you give them the metric and they say, oh, that's doesn't actually give me my answer. You should work to ask them, what are you looking to achieve? If I give you this data point, what are you hoping it tells you? Because a lot of times it's not actually the metric that they're asking for. And then you'll also notice that everyone's asking for the same metric in different ways. So I think as an analyst, try to pull out those nuggets in conversations you're having and in meetings that you're in. You can really understand, oh, this is what they mean when they say this. So first, I would say just learn your team. And then as an operator and a leader, I mean, you set that pace, right? If you're in a clinic and this is our patient population, this is the need here, you set that. You use your data to set the pace and make sure that you're keeping everyone on track. Post it somewhere, post it in your break rooms, talk about it at every meeting. Make it very clear that, of course, we are doing a lot of things, but this is my number one or this is my top three. And I think that's the hardest, is actually making people say we're not doing everything and reminding everyone that no is also a strategy. So if you're not a leader, if you're not an operator, ask your leaders or operators, okay, you said we're doing this, this, and this. Give me your top three. If you could only ask for one thing, what would it be? And kind of pull it out of them that way. But strategy fatigue is a very real thing. I would love to, if you have any tips or tricks, reach out to me. That's a very real problem, especially as organizations get bigger. It's a lot to manage, but just try to think of how you can do your part within your role, and kind of navigate some of the discussions and conversations around it.
Thank you so much for that, Molly. That was great. It doesn't look like we have any more questions, so I do want to thank you again, Molly, for such a wonderful seminar today. Thank you so much for your time. And I also want to thank all of our attendees. Thank you all for attending today. As you can see on the screen, here is Molly's email. So if you have any additional questions outside of our seminar, please feel free to reach out to her. Um, and I just want to thank you all again and have a wonderful rest of your day.
Thank you guys.